I heard you were in pain. Tell me, what's going on?
My tooth hurts really bad. Now I can't chew on this side. I've had this happen before. I just need an antibiotic, right?
The last couple of cleanings that I had, my surgeon had me take an antibiotic beforehand. Should I have taken one today?
Antibiotics are one of the greatest developments in modern history. The discovery of penicillin in 1928 by Nobel Prize winner Alexander Fleming transformed medicine and saved millions of lives. However, Fleming warned of selection for resistant bacteria that could threaten the efficacious nature of antibiotics. As Fleming predicted, antibiotic resistance has become a significant public health crisis. In 2019, the Centers for Disease Control reported that there were nearly 2.9 million patients in the U.S. with antibiotic-resistant infections and nearly 36,000 deaths annually. It has been predicted that if antibiotic resistance continues to increase at the current rate, there will eventually be more deaths due to antibiotic resistance than due to cancer. The current crisis is linked to the overuse and misuse of antibiotics, making the practice of antibiotic stewardship urgent. It is reported by the CDC that nearly 1/3 of all outpatient prescriptions are unnecessary. A collective effort is needed by all healthcare professionals to learn, educate, and implement guidelines for proper antibiotic use. Dentists are significant contributors to the number of antibiotic prescriptions. As a profession, dentists account for roughly 10% of outpatient antibiotic prescriptions each year, equating to approximately 25 million antibiotic courses. This study from the Journal of the American Dental Association shows that dental providers are the third highest prescribers of antibiotics. Additionally, antibiotic prescribing for oral infections in the emergency department accounts for a large number of prescriptions. This graphic shows the top 10 antibiotics prescribed by dentists. Of concern is that clindamycin accounts for 15% of antibiotics prescribed, making dental providers the most common prescribers of clindamycin, an agent that has significant association with Clostridioides difficile, C. diff, diarrhea. In dentistry, antibiotics are prescribed for one of two things: treatment of oral infection or for prophylaxis in patients undergoing dental procedures. Historically, there has been little data around the appropriateness of antibiotic use in dental patients. In one of few published studies, it was found that nearly 81% of antibiotics prescribed for prophylaxis were not consistent with guidelines. Up until November 2019, there were no guidelines for the use of antibiotics in oral infections, and consequently, no data existed describing appropriateness. The American Dental Association, or ADA, recognized the need to improve antibiotic management of oral infections. This prompted them in 2018 to join the Antimicrobial Resistance Challenge, along with more than 350 organizations worldwide. The ADA committed to developing the first guidelines on antibiotic use for the management of oral infections. The intention is to generate consistency in antibiotic treatment plans and to change the focus of antibiotic use from just in case to only when necessary. In November 2019, the ADA published evidence-based clinical guidelines on antibiotic use for the urgent management of pulpal and periapical-related dental pain and swelling. The guidelines are intended for use in adult, immunocompetent patients. Let's take a look at how these guidelines may be used in practice. John has come to see his dentist, Dr. Pine, today because he is experiencing dental pain.
So, John, I'm glad we got you in today. I heard you were in pain. Tell me, what's going on?
My tooth hurts really bad. Now I can't chew on this side. It started about 3 days ago. Now the gum's swollen. I've had this happen before. I just need an antibiotic, right?
I'm sorry to hear that your tooth is bothering you, but I can see why you think you need antibiotics because that's how you were treated in the past. Recommendations have actually changed regarding the use of antibiotics for tooth infections. So let me just take a look so I can tell what's going on. We can take an x-ray, and then we can decide together what we should do. Sound okay?
Yeah, that sounds good. It's nothing too serious, is it?
As Dr. Pine manages the treatment of John, she will carefully consider the need to prescribe antibiotics. In conjunction with the ADA guidelines, 2 chairside guides were developed to ensure efficient and consistent care that she will be referencing. The primary difference between the 2 guides is that the recommendations are based upon whether or not definitive, conservative dental treatment, DCDT, is immediately available, purple header, or is not immediately available, orange header. DCDT is a new term developed specifically for these guidelines. DCDT refers to pulpotomy, pulpectomy, non-surgical root canal treatment, or incision for drainage of abscess. Immediately available refers to DCDT being performed within 1 to 2 days. Let's take a look at how Dr. Pine uses the chairside guide to treat John's tooth pain.
Well, you do have an infection, you have an abscess, and the x-ray confirms it. I would like to open that tooth up and drain it today, and that should relieve a lot of your pain and swelling. Before we talk about whether or not you need antibiotics, I noticed on your chart that you have an allergy to antibiotics. What do you remember about that?
I used to get ear infections when I was a kid. Once I broke out in a rash, and I was told to not take amoxicillin again.
Okay. Do you remember anything else, like any trouble breathing?
No, just the rash the one time.
All right. Well, if we do decide to give you antibiotics, I will have a few more questions to ask about that. But let's drain that abscess so you can start to feel better.
Okay.
Okay.
It has been shown that 10% of the population state that they have a penicillin allergy, but less than 1% of the population has a true allergy. Dental patients labeled as penicillin allergic are more likely to receive clindamycin, which poses the greatest risk for the development of C. diff diarrhea. Dental providers are in a unique position to help in this effort to delabel patients who do not have a true penicillin allergy or whose allergy has waned over time. In many cases, drug side effects such as stomach upset and diarrhea may have been inappropriately identified as allergic reactions. Additionally, approximately 80% of patients with IgE-mediated penicillin allergy will lose their sensitivity after 10 years. Therefore, there are many patients who have documentation in their electronic health record, or EHR, that they are allergic to penicillin, who are not truly or currently allergic. If a patient has not experienced difficulty breathing, hives, or anaphylaxis, or if their reaction was more than 10 years prior, the dental team may suggest that the patient follow up with their primary provider or allergist. A simple skin test can be performed, and if negative, the allergy can be removed from the EHR. This will allow the patient to receive the most appropriate antibiotic therapy for any future infection they may have. The Michigan Antibiotic Resistance Reduction, or MAR, Coalition has collaborated with the Organization for Safety, Asepsis, and Prevention to develop a tool that can be used chairside to assess whether the patient may benefit from seeking further evaluation of their allergy by a healthcare professional. Let's see if John will need antibiotics and how his allergy history impacts the antibiotic prescribed.
Since we've drained that abscess, you should be feeling a lot better. And you really shouldn't even need to take an antibiotic. But since there is a small chance that the infection might come back, I will write you a prescription. Just don't fill it right away. Please wait a couple days, and as long as you're feeling better, you won't need it. See, when we take an antibiotic, both the good and bad bacteria are killed, and that can lead to some side effects that you don't want.
All right.
All right, I have this for you. Now, this will remind you of how long you should wait before filling your prescription and also which over-the-counter medications might help.
All right, thank you.
And if you do end up filling the prescription, you might not need to go the full 7 days. You can stop one day after you feel better.
Oh, I was always told to take the full prescription.
Yes, that's true. In the past, you were supposed to finish the whole prescription, but we now know that a shorter duration can be as effective with less side effects.
Okay.
I am writing you a prescription for Keflex. Now, normally I would prescribe amoxicillin because it's considered a narrow spectrum antibiotic, meaning that it will kill less of the good bacteria as, say, a more broad spectrum antibiotic like Keflex could. But because of your previous reaction to amoxicillin, I want to stay on the safe side.
Okay.
I do recommend that you talk to your doctor about this. Knowing whether or not you have a true allergy to amoxicillin can make it safer for you to take a more narrow spectrum antibiotic for any future infections.
Okay.
John received DCDT today, so Dr. Pine referred to the chairside guide with the purple header. Since John did not have systemic involvement, antibiotics were not indicated at this time. However, because of John's history of previous infections, and because he was in the office on a Friday afternoon, Dr. Pine decided that a delayed antibiotic prescription would be indicated. She wrote for Keflex since John did not report a history of anaphylaxis, angioedema, or hives when he had amoxicillin as a child. The ADA referenced studies supporting the effectiveness of delayed antibiotic prescribing in respiratory tract infections when developing their recommendations to use this practice in the management of oral infections. These studies have shown that delayed prescribing reduces antibiotic consumption while maintaining patient satisfaction. A delayed prescribing tool was developed using a CDC template. MAR worked collaboratively with the Michigan Dental Association to create the tool to guide patients on conditions which may warrant them filling the prescription. On the back side of the tool, there is guidance around pain management. Importantly, recommendations are made to avoid opioid agents in the management of dental pain, consistent with both the ADA statement published in 2016 and with recommendations in the guidelines for management of oral pain and swelling, published in November 2019. If John does fill the prescription, the dentist has written it for a maximum of 7 days and has advised him to stop taking it 24 hours after his symptoms have resolved. Over the past 2 decades, numerous studies support shorter durations of antibiotic therapy for a variety of infections. For example, the recommended duration of antibiotic therapy for community-acquired pneumonia, a disease that has a high incidence of morbidity and mortality, was decreased from 10 to 14 days to less than or equal to 6 days. Longer durations of antibiotic therapy drive resistance and disrupt our host microbe symbiosis, putting the patient at risk of GI side effects, including C. diff diarrhea. As discontinuation of antibiotics before completion of the entire prescription is a new concept that may lead to more leftover antibiotics, patients should be counseled about proper disposal of unused antibiotics. Antibiotics should not be flushed, so they do not end up in water systems. Upon referencing the MAR penicillin allergy tool, Dr. Pine recommended that John should follow up with his primary care provider to reevaluate his allergy. Ultimately, the goal would be to remove the penicillin allergy label from his electronic health record, if appropriate. It is important for the entire dental team, including dental assistants, hygienists, etc., to be able to discuss with the patient their penicillin allergy history and guide the patient to further follow up with their medical provider. Now that we have looked at antibiotic stewardship with treatment of oral infections, let's turn to the use of prophylactic antibiotics prior to dental procedures. Mr. Sanders is in for a routine cleaning. He is 62 years old and has diabetes that is well controlled with oral medication. He has a past medical history of prostate cancer and had a hip replacement more than a year ago.
I'm glad you are feeling well, Mr. Sanders. Today should be an easy visit because you've been pretty good about keeping up with your routine cleanings. Are you having any trouble with your teeth?
No, everything's been going really well. I've been flossing more too.
Oh, good. That's great to hear.
I am curious though, the last couple of cleanings that I've had, my surgeon had me take an antibiotic beforehand. Should I have taken one today?
Oh, good question. Because of your hip replacement, your surgeon may have been erring on the side of caution by having you take a prophylactic antibiotic. Actually, we now know that you can get just as much bacteria in your mouth when you brush your teeth as you do during a dental cleaning. Because of this, antibiotics are not recommended prior to a routine cleaning.
Oh, really? You don't think I should take one just in case? It never seemed to do any harm before.
Well, actually, the recommendations have changed because the risk of taking an antibiotic before a cleaning may be greater than the benefit they provide. Antibiotics actually kill the good bacteria in the stomach that keep everything in check and can cause some nasty side effects like diarrhea.
Is that so?
Yes, there's so much more awareness these days about C. diff diarrhea. So that's why our dental practice is really committed to using antibiotics safely. This brochure explains why.
There are two patient groups that are considered for antibiotic prophylaxis prior to invasive dental procedures, such as tooth extractions, root canals, and deep cleaning between the tooth root and gums, patients with certain cardiac conditions, and patients with prosthetic device implants. For patients with cardiac conditions, in May 2021, the American Heart Association reaffirmed that there is a relatively small subset who require antibiotic prophylaxis to prevent infective endocarditis. This is based on a review of scientific evidence, which showed that the risk of adverse reactions to antibiotics generally outweigh the benefits of prophylaxis for many patients who would have been considered eligible for prophylaxis in previous versions of the guidelines. Among the risks considered was the development of drug-resistant bacteria. The specific cardiac conditions that warrant antibiotic prophylaxis are detailed on the ADA webpage. In these patients, a single dose of an antibiotic 30 to 60 minutes prior to the procedure is warranted. The recommendations for antibiotic prophylaxis in patients with prosthetic devices have evolved over the years. At times, the recommendations of the ADA and the American Association of Orthopedic Surgeons, or AAOS, were not always aligned, leading to confusion and unnecessary antibiotic use. In a retrospective study of 91,438 dental patients who received antibiotic prophylaxis, it was reported that more than 80% of the prescriptions were outside of guidelines. The ADA generally recommends against prophylaxis. The clinical reasoning is provided by the ADA in their chairside guide. In regards to the first and second bullet points, it's notable that the organism that is the primary cause of prosthetic device infections, Staphylococcus aureus, is not considered an oral pathogen, and it is not covered by the antibiotics used for prophylaxis in dentistry. In 2016, the AAOS and ADA worked collaboratively to develop clear, consistent guidelines for the management of patients with orthopedic implants undergoing dental procedures. Consequently, the AAOS developed an appropriate use criteria tool that is available online. Once the patient is a year out from their implant, they generally will not be following up with their orthopedic surgeon on a regular basis. If the patient believes they still require a prophylactic antibiotic before dental care, they should consult with their orthopedic surgeon or primary care provider. The individual patient's circumstances and preferences should be considered when deciding whether to prescribe prophylactic antibiotics prior to dental procedures. In the case of Mr. Sanders, the guidelines would not indicate taking a prophylactic antibiotic. Let's see how the dentist follows up with Mr. Sanders' concerns.
Well, Mr. Sanders, your teeth look great. Yvonne gave you a good cleaning, and she told me that she talked with you a bit about the current recommendations for using prophylactic antibiotics. Do you have any questions about that?
No, I don't have any questions looking at that brochure. It makes sense to avoid taking antibiotics if I don't need to.
And because you've had your prosthetic hip for more than 1 year, the recommendations now say that you wouldn't even need a prophylactic antibiotic for more invasive dental procedures, like a root canal or an extraction.
That's good news.
Dr. Pine was confident that the hygienist had counseled Mr. Sanders about the changes in prophylaxis in patients with prosthetic devices. If Mr. Sanders had asked additional questions, the dentist may have chosen to use the appropriate use criteria tool developed by the AAOS. The online tool is freely accessible and may be useful in discussions with both patients and orthopedic surgeons who continue to insist on antibiotic prophylaxis. After inputting patient-specific parameters, a printable report will be generated with recommendations based on current guidelines. This online tool may also aid in bridging the communication gap between orthopedic surgeons, primary care providers, PCPs, dentists, and patients. An important update that the AAOS made in the tool was the removal of clindamycin as an option in patients who state that they have a penicillin allergy. In penicillin-allergic patients without a history of anaphylaxis, cephalexin, Keflex, is recommended. For patients with a history of anaphylaxis, azithromycin, Z-Pak, is recommended. Pediatric recommendations are also provided. Ultimately, it is the healthcare provider's decision on when to prescribe prophylactic antibiotics, and other factors not included in the tool may influence the dental provider as to whether the benefits of antibiotics outweigh the risks in a specific patient. For example, if the patient has a prior history of having C. diff diarrhea, then the dental provider may opt to avoid antibiotics, even if the tool suggests that it is sometimes appropriate to prescribe. Dental providers prescribe approximately 10% of outpatient antibiotics in the U.S., and therefore are key stakeholders in implementing antibiotic stewardship practices as outlined by the Centers for Disease Control. And since patients often see their dentist more frequently than their primary care providers, there's an opportunity to educate patients so they can be antibiotic stewards. Many of the stewardship tactics outlined in the 2019 ADA guidelines, for example, delayed antibiotic prescribing and early antibiotic discontinuation, are evolving practices with a low level of both public and healthcare provider awareness. It's essential for all dental staff, especially hygienists and front desk personnel, to understand these new approaches so they are able to help educate dental patients. The MAR Coalition has developed a webpage dedicated to dental providers that contains the ADA chairside guides, links to ADA sites, and other relevant references. The tools developed by the MAR Coalition may be requested for the dental office at no charge, and the provider commitment poster can be personalized for the dental practice. These personalized posters have been shown to impact patient expectations around antibiotic prescribing, helping them to better understand the risk-to-benefit ratio. The MAR patient brochures can be made prominently available, for example, at the front desk, so that patients can read at their leisure. By addressing antibiotic stewardship in your practice and educating your team, you will be helping to ensure a safer dental visit.